After 60 people start hearing a different kind of sentence in the exam room, we can do a procedure for that. And sometimes that sentence is exactly what you need to hear. But sometimes it is not. Because one of the biggest mistakes people make after 60 is assuming that if a procedure is offered, it must automatically be the smart next step. It feels logical. There is pain, there is a scan, there is a specialist, there is a procedure. Problem identified, solution offered, done. But real medicine is not that clean. A procedure can be available without being necessary. It can be common without being clearly helpful. And it can make perfect sense in one patient while being the wrong move in the next one sitting 3 feet away. That is especially true after 60 when anatomy gets messier, MRI reports get longer, incidental findings get more common, and the gap between something can be done and something should be done gets wider. That is why shared decision-making is emphasized in modern guidelines for chronic coronary disease, and why so many evidence-based intervention programs now exist specifically to reduce procedures that are often overused or poorly targeted. So if I were talking to a family member over 60, there are 4 procedures I would not automatically reject, but I would absolutely slow down and question hard before agreeing. The first is knee arthroscopy for wear and tear knee pain. This is one of the classic procedures that sounds more precise than it often is. The story goes like this. Your knee hurts, the MRI shows a meniscus tear or arthritic change, and the idea of cleaning it out feels intuitive. If something looks damaged, surely going in and trimming, shaving, or washing the joint should help. That logic is powerful. It is also the reason so many people got procedures that evidence later struggled to justify. The BMJ Rapid Recommendation made a strong recommendation against arthroscopy for degenerative knee disease in nearly all patients, and the summary notes that this applies even when imaging shows osteoarthritis, meniscal tears, mechanical symptoms, or sudden symptom onset. The underlying reason is simple. For most older adults with degenerative knee disease, the average benefit is too small to justify the pain, cost, inconvenience, and procedural risk. And this is where people over 60 get trapped. Because MRI findings become more common with age, meniscal degeneration becomes more common with age, arthritic changes become more common with age. So the scan starts looking dramatic, and the patient assumes the scan is the explanation. But age-related findings are not always the pain generator. That is why a procedure that seems anatomically neat can still disappoint functionally. Would I say knee arthroscopy is never appropriate? No. An acutely locked knee, a true traumatic injury, or a very specific injury pattern is a different conversation. But for the typical over 60 scenario, chronic knee pain, degenerative meniscus language on MRI, and arthritis already in the joint, I would absolutely ask, what is the evidence that this procedure will help me more than exercise therapy, time, injections, weight loss if relevant, and pain management? For most people in that lane, the answer is weaker than they expect. The second procedure I would seriously question is an elective stent for stable coronary disease when the expectation is that it will prevent a heart attack or extend life. This is one of the most emotionally difficult conversations in medicine because the logic feels overwhelming. If there is a blockage, open it. If there is narrowing, fix it. If there is chest discomfort and a cardiologist says stent, people hear one thing, safety. But stable coronary disease is not the same thing as an actively evolving heart attack. And in stable patients, that distinction matters a lot. The ischemia trial did not show that a routine initial invasive strategy reduced major adverse ischemic events compared with optimal medical therapy in stable patients with moderate ischemia. Modern chronic coronary disease guidance also emphasizes patient-centered care, shared decision-making, and guideline-directed medical therapy, rather than treating every stable blockage like an automatic stent problem. NICE likewise recommends optimal drug treatment first, for stable angina, and says revascularization should be considered when symptoms remain unsatisfactorily controlled despite medical treatment. That does not mean stents are useless. They can absolutely matter for symptom relief. They can be life-saving in acute coronary syndromes. They can be the right move in carefully selected anatomy and clinical contexts. But if you are over 60, stable, not in the middle of a heart attack, and someone is offering a stent, the question I would want answered very clearly is this being done mainly to improve symptoms, or are you telling me it changes my risk of death or future heart attack in my specific case? Because many patients still believe PCI in stable disease automatically prevents heart attacks. And that misunderstanding is exactly where bad consent starts. The third procedure I would seriously question is vertebroplasty or kyphoplasty for an osteoporotic compression fracture unless the case is very clearly the right one. This is another procedure that sounds more straightforward than it is. The pitch is simple. There is a compressed vertebra. The back hurts, stabilize the fracture, inject cement, get relief. And for some patients with a recent unhealed fracture and severe ongoing pain despite optimal pain management, that may be appropriate. Nice. Does recommend vertebroplasty and balloon kyphoplasty as options, but only in that narrow situation, and only when the pain has been confirmed to be at the level of the fracture by physical examination and imaging. That narrow wording is the whole story, because once the fracture is older, once the pain source is less certain, or once the back pain is more diffuse and chronic, the procedure deserves much harder questioning. The mistake people make after 60 is assuming that if a fracture appears somewhere on imaging, then that must be the pain generator. But back pain in older adults is often layered. Arthritis, deconditioning, muscle guarding, spinal stenosis, prior fractures, posture changes, and pain sensitization can all overlap. A cement procedure only makes sense if the fracture is truly the culprit and truly recent. That is why I would ask, how sure are we that this specific vertebra is the reason I still hurt, before agreeing? The fourth procedure I would seriously question is epidural steroid injections for chronic back pain, when they are being presented like a durable fix. This one is tricky because a lot of people feel some relief after these injections, and I do not want to dismiss that. But the newer neurology evidence is pretty clear on the overall pattern. Epidural steroid injections can provide modest short-term improvement in pain and disability for some patients with radicular pain, but the long-term benefit is limited, and they do not appear to reduce the need for surgery in the broad way many patients imagine. That means the right question is not, can this help at all? The right question is, what kind of help are we actually talking about, for how long, and for what exact diagnosis? Because chronic low back pain, spinal stenosis, and nerve root irritation often get blended together in everyday language, while the evidence is much more diagnosis-specific. If a patient hears injection and imagines a reset button, the expectation is already wrong. For some people, a short-term reduction in pain is valuable. It may help them sleep, participate in physical therapy, or get through a flare. That is reasonable. But if the procedure is being sold as though it predictably fixes chronic back pain long-term, I would slow that conversation way down. So if I were summarizing the four, it would be this. Knee arthroscopy for wear and tear knee pain, usually far less helpful than people think. Elective stenting for stable coronary disease, may help symptoms but is not the same thing as this saves my life in every stable case. Vertebroplasty or kyphoplasty, potentially reasonable in a narrow, clearly selected fracture scenario, not as a reflex for every older adult with back pain and a compression fracture on imaging. Epidural steroid injections, sometimes useful for short-term relief, but not the durable cure many patients are led to expect. And the bigger lesson after 60 is this. Do not ask only, can you do this procedure? Ask, what happens if I do nothing for now? Ask, what is the best non-procedure alternative? Ask, is this meant to improve symptoms, function, longevity, or all three? Ask, what is the evidence in someone like me? Because that is where the real decision lives. Not in whether a procedure exists. In whether it is truly the best next move for your version of the problem.